Hardik is discussing.
Dispur is discussing, sir. Priyanku.
Who? Priyanku.
Priyanku.
Yeah. Priyanku,
Yes, good morning, sir.
good morning. Welcome.
Thank you, sir.
What is this? Why is this looking all glassy and grey and white? It's not how we usually see, isn't it?
Yes, sir.
So, is something wrong here?
There's something wrong with the patient's body, something wrong with technique.
Why is it all grey? Absolutely no differentiation between tissues and just looking at grey. Anybody else? The answer is very easy. If you know the technique of CT, or in the earlier days, even X-rays. See, this is nothing, it's a good CT. This is a soft tissue window.
Okay, sir.
Okay, it involves less radiation and is today recommended even for stone screening. They say don't do the full thing, do the soft tissue and you're exposing the patient to less radiation. Okay, this you must be aware of
Okay, sir.
because the examiner will ask you, why
Okay,
is it
sir.
looking like this? You might as well comment on the findings also.
Sir,
Go up one slide. Yeah.
sequential axial section images of the patient.
See, when they ask you what are the findings, you don't have to go to that. If they ask what imaging is that,
Yes,
then
sir.
you can tell them all this. Don't waste time. Okay? Yeah, what are the findings?
Sir, both the kidneys are hydronephrotic
Okay.
with normal contour, regular border.
See, I'll tell you something. For films like this,
Yes.
you can't describe the kidneys other than the hydronephrosis, size, location, and orientation. Okay? Don't
Yes.
waste time. You'll get better images where you can see the kidneys better.
Yes.
Okay, hydronephrosis, both sides. Then,
Is there a gallstone or something?
Yes, sir. There is a radiodens. The radiodensity within the
see, we've
lobe-
discussed this last time.
Yes, gallstone.
Can't be anything other than a gallstone. We found it
Yes.
sitting within the gallbladder, right? So this is why they recommend the soft tissue sequences today, because stones can be picked up easily with less
Yes.
radiation. Okay.
Can move to the arterial phase.
No, whatever is the sequence you have next. Can you see any bowel? Okay, doesn't matter. Go up. Show that liver again. Up.
You can see, sir.
Up, one more sequence up. One slide up.
Can you see, sir?
Yeah, no, show the next one. Liver.
Okay.
One before what you showed now.
Can you see, sir?
We can see IT. Yeah. Yeah, move down. Stay there, stay there. Don't turn. Stay there. Anything else you see here? Priyanku?
Sir,
What are those lucent areas within the liver? You can see at least 6 of them.
they can be small hepatic cysts
Or cyst is one diagnosis. What else?
it can be biliary ducts.
Dilated biliary duct.
Yes.
But there's a different characterization for ducts, but we'll accept it. Let us say we are not hepatologists. Ducts will usually have a ring around them of their muscle tissue and fibrous tissue. Okay? That's how in the liver we differentiate between duct, vessel, and cyst.
Cyst.
Yeah.
Okay, sir.
Okay, let's move on.
So,
Just Priyanku, now it's all yours. Go up, please, a little. Yeah, stay there.
yes. So,
When was this CT sequence? Is it straight from your right to the front or straight from somewhere else?
Okay, other than the kidneys and the vessels, what are the structures you can see and describe anything unusual or abnormal?
sir, there is periodic
Structures meaning anatomical identified structure, organs or vessels or things like that.
so we can identify the bowel, large bowels ascending and descending.
Okay.
Then we can visit.
What about them? Are they normal or abnormal?
Sir,
See, there's a whole lot of fecal matter on both sides. You have to describe that. Okay. And then what else? There is one very important and prominent structure that you can see.
So the pancreas.
Yeah, you can see the pancreas.
Yes.
The duct seems a little dilated, but there are no stones. We
Yes.
don't know. We'll see as we go along. Yeah,
Then you can visualize the stomach anteriorly, sir.
right. Go on. Hey, somebody please get a cup of tea for Kamal Man.
So we're moving down and you can
At what level are we now? At what vertebral level?
sacrum, we have L5 levels.
More likely S1.
Yes, yes.
Because the sacrum is well formed
Just
and you
sacrum
can
is
see
visible.
at the central body. Okay.
Yes, sir.
Okay.
So,
If there's anything here, tell us. Did any of you or all of you read up about RPF?
Yes, sir.
yes, yes.
Theory question was there.
The theory question is something reading up. Nice, good. Yeah. If there is, say yes, this abnormality. Otherwise, say no, we'll move along.
It appears normal, sir. In the,
What are you looking for? At this level,
yes.
what would you be looking for? Dr. Ganesh answered this. Last time he answered me, he gave you the description.
Poor quality CT scan.
Yeah, I think this is one of those earlier ones.
The vessel has bifurcated on both sides. That we see the common iliac arteries and the ureter.
Dr. Ganesh described something related to RPF. There's some anatomical details. Do you remember? From where to where does the plaque extend?
Sir, superiorly it extends up to renal to the level of the renal artery or the renal hilum. Rarely above that level, and inferiorly it is usually up to the pelvic brim, sir. It is unusual below the pelvic brim.
So this is the pelvic brim.
Yes, sir.
So you should look for it. Okay. Move on.
Very nice.
Hey, go up. Go up a little. Don't run, Kamal. Looks like the tea has come. Go up. Yeah, come down now. A little. Wait, slowly. Yeah, a little. A little. The next one. The next one.
Is this the best CT scan we have for this patient, or is there anything better? Is that it? Is it? Kamal?
We have excretory phase also, sir.
Nay, do you have something
X-ray, yeah.
with better resolution?
No, sir. Resolution is this only, sir.
That's all, huh?
Yeah, this is from the console. Video has been made, I think.
Even then.
Very bad. I think Priyaku has the right to say that this is a lousy CT scan.
And tell them, get me another one.
See, sometimes it is very difficult. You have the clinical evidence, you have the uterus, but you still don't see the plaque. That's because the amount of tissue and the amount of inflammation that is there in the tissue could be very little. It could be not a huge plaque, it could just be a thin sheet. And therefore, you may not be able to see these unless the CT or the MRI
is high resolution.
The CT may not show, but the MRI gives you better tissue delineation. So if you have a high index of suspicion, you have to do that. And that doesn't work. And last time we discussed the FDG PET. So, Yes.
Yep. That one. Up. One slide up. Yep. Hey, down. You're going Too far up. Yeah. Anything here, Priyanku?
You can see the distended bladder, which is slightly thickened wall, and the
Say that
rectum
first. Say the bladder wall is thickened.
thickened.
What else?
The bladder lumen is
छोड़ दो
appears
नहीं चाहिए वो सब.
prostate is enlarged. It is
Unilobar, bilobar.
bilobar.
Prostate is a seminal vesicle. Next, please. Hey, don't run, man.
Sir, fast video is it?
See, here you can see a structure in the midline, which we will accept as prostate.
Yes.
What was the previous one? Is it in the midline? Go up. Go up one slide. Here, do you find those bulges in the midline?
No, sir. It laterally.
What else is there? There seems to be a isthmus kind of thing between the two, isn't it?
Yes, sir.
So we have to wonder what this is. I mean, it could well be extensions of the prostatic lobes,
Yes.
but you won't find them so laterally.
Yes, sir.
Okay. This is a prostate.
Yes, sir.
Okay. Move, please. Move. Let's see the rest of the sequence. Not this. I'm saying next one. You said something you have of something.
Yeah.
Yes. So these are the biographic sequences. And
Describe what you see. Go up. Hey, you stop at each image. Next down. Yeah, why am I showing you this?
hydronephrosis is there, sir.
Yeah, at multiple levels. This particular thing, why am I showing?
Just one minute. Let me go to next to the third signal. Hang on, just a minute.
What about the pelvis?
It is on the left side, you can see the renal pelvis. On the right side, the calyces are visible.
Is
There
it
is
normal?
calyces.
Is the pelvis normal? See, dilatation has started,
Yes.
right? Okay, go down. Down.
Now you can see the pelvis
That's
on
all
the right
right.
side.
Down. Down. So the pelvis and here the ureter
The
are still
ureter.
dilated, right?
Yes. Yes, sir.
Go down. Go down.
Dilated ureters.
Go down. What's happening here?
There is a nasal tapering of the ureterals
You
segments.
can't say tapering in an X-ray scan.
Yes.
They have become narrow,
Narrowing, sir.
narrower than earlier. This is still
They have
normal
become-
caliber, but it's narrower than what we
Yes.
saw earlier. Okay.
Sense.
Go down. So this is still at the level of the renal item.
Yes.
Remember that. Yeah.
So
Wait.
On the-
I'll show you. I'll show you more. Wait.
on the right side, it is narrower.
Wait. See, you said narrow. So let
Yes.
us see what happens as we go down.
Yes, sir.
Okay, down. What's happening here? It again seems to be dilating,
Yes, sir.
right? Yeah.
Yeah.
Right side is narrowed again. Can you see?
Narrower.
And
Yes.
what's happening around the ureter on the right side?
It is being encased by peri
By soft tissue.
soft tissue, sir.
Okay, go down. Next. 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 Next.
It is being pulled medially, usually.
Okay, that you can make out in the earlier slides also.
Yes, sir.
Down. Next, please. Next, please. Next, please. Yeah. Next, please. Yeah. Next, please. So,
Next.
what you found
And then
was the ureter dilated initially, then narrowed, continued to be narrow, and slowly assumed its normal caliber. Right?
Yes, sir.
So that much description will do. You don't have to each sequence say this is narrow, that is narrow.
Okay, sir.
It all falls into one pattern.
Can I add one thing, sir?
Yes, sir, you are the boss.
So right side it is more involved and more medialized.
Yeah, probably. Because left side we don't see much of a soft tissue.
And narrowing also, sir.
But that doesn't change anything so much.
Yes, sir.
In the bilateral disease, it's just that sometimes one side may be more apparent. It's well known, and that's the reason why prophylactically you do the other side also. If it's not very, very clear, just give trouble later.
Yes, sir.
Yeah. Next. 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 Good on, finish the sequence. finish.
Yes, sir.
Finish the sequence. We won't find anything more pertaining to this case. ओ छड़ परे
Sir, मैं
की कर रहे हैं?
I'm going to slide, sir.
Yeah, please. Yeah.
Arey bhaiya, next time don't show X-rays like this, man. You're trying to imagine a lot of things.
There are so many interesting findings. If you take a good CT, not just about the plaque, but about the kidneys and other structures also, we have missed out completely on them.
According to this, according to the report, the extensive thing going down into the pelvis too.
Pelvis.
Yeah, which is not apparent at all in the images that have been shown. So
Correct.
we'll have to assume, we'll have to take the CT report as gospel truth at the moment.
We could see at the pelvic brim some plaque still present. But then without good resolution, very difficult to say.
It is important, therefore, on the basis of this CT, if you do decide to operate, that you've got to go right below the iliac bifurcation and free the ureter completely and do whatever else you want to do.
Okay, so Priyanku,
Yes, sir.
you have the report. I know you'll get lab tests, you'll get DMSA, DTPA, everything done. We may agree with some, we may not, but all that has been done, and the patient wants to know what you're going to do. Or patient says you do whatever has to be done. So what do you propose to do?
Sir, first initial management will be to deal his hydronephrosis, sir. So we decompression of the kidneys by
Don't use
Drilling.
long sentences. Just say, I will stent or I'll do a PCN.
patients.
Everybody knows why you are doing it.
What is the creatinine of this patient? Just to refresh our memory.
0.79, sir.
Sorry?
Normal.
0.79.
0.7. Right.
Normal.
Okay. So now are you sure you are by doing a CT, by doing something, you are going to improve the creatinine from 0.7? Are you treating disease and kidney? Are you treating only kidney?
Sir, disease and kidney, sir.
Disease and kidney, right. So how will you decide which you will treat first? Kidney and disease? Right? What is so difficult, man?
Yes.
If creatinine is
The patient,
0.79
Yes.
and creatinine is 4, is there any difference? At 4, which will you treat first? At 0.79, what will you treat first?
Okay, sir. Sir, at 4, we need to decompress the kidneys first by stenting or PCN. And since this patient is
0.79?
not having a
At 0.79? Patient will read up, come and say, no, I heard for hydronephrosis, there's this procedure called stenting.
Yes.
It does not involve cutting, it does not involve major anesthesia. Please do that for me. How will you
What is the patient's Priyanku, what is the patient's symptom?
Sir, he had flank pain, sir, which was relieved by use of some analgesics. So that is why if we decompress the kidneys at
You are sure that the flank pain will disappear after you decompress the kidney?
Some general principles applied across diseases and cases. We have discussed so many times mechanism of renal pain. So you think of that and see whether there's any benefit. If so, how? If you see no benefit, then you say no. By the way, let me also mention here, one of the characteristics of RPF pain is it's very difficult to relieve with analgesics beyond a point. Okay.
yes.
The pain is, it's a vague backache, and it's a common symptom. It's a common symptom probably in the absence of other evidence like edema of the feet and weight loss and stuff like that. But back pain is there, but it's such a vague symptom, and there's no doubt about the fact that these patients do have a pain related to the plaque. See, Priyanku, the decision you'll have to make here is you have got both kidneys are functioning well. The creatinine is normal at the moment.
Yes.
You have to assess the activity of the disease. First of all, on the basis of this CT scan, you are clear now that this looks like the classical idiopathic RPF, right? If you
Yes.
out on the imaging that this does not fit into the characteristics of the idiopathic RPF, then you will have to go for a biopsy, either a CT guided or whatever guided biopsy.
And look for other conditions
Yes.
which can cause secondary retroperitoneal fibrosis.
Right?
Yes.
Now, the other thing to do is once you are certain that this patient has got idiopathic RPF, you will have to see how much of disease activity is there. And how do you assess disease activity? How do you assess disease activity in RPF?
Sir, we can do a PET CT or MRI, sir.
MRI.
No.
How do you assess disease activity in rheumatoid arthritis? How do you assess in all these autoimmune disorders? How do you assess disease activity?
Autoimmune markers assessment, sir.
Right. Do we have any markers here in RPF? Do we have any inflammatory markers which they have shown us actually? The previous slide they showed it. I don't know whether you saw it.
CRP.
Yes. What else? See, there are three markers.
Yes.
The fourth marker is just to find out whether they've got that disease at all or not. But the treatment doesn't change because you've got IgG4. But
Yes.
ESR, LDH, and CRP are the inflammatory markers that are usually used for RPF.
Yes.
Recommended nowadays that if there is degree of inflammation and if the renal function is actually normal, you can start these patients directly on medical therapy.
Okay, sir.
Because putting a stent in is not going to improve the function. It might add to another series of issues which you may not want.
Yes, sir.
There are patients who actually, the plaque does actually regress in size a bit, the inflammation settles down and the ureters continue to be draining. The important thing is what is happening to the creatinine.
Yes.
What is happening to the creatinine and the GFR of each kidney has to be monitored very carefully. So the onus is on you. The onus is on the doctor who is not deciding to put a stent in, but do this thing. All right? The easiest thing is to put a stent. The easiest thing is to put the stent.
Yes, sir.
The more difficult thing is not to put a stent, but follow this patient up with inflammatory markers, start him on medical therapy, and then see how he progresses. You don't lose anything.
When stents first came in, a lot of people used to stent because it was now available. You will find the plaque can compress the stent also and sometimes infiltrate into the ureter and involve the stent. We've seen this happen.
Yes.
So, stent is not the solution, but it should not become the problem.
See, one of the things that we don't we must remember in RPF is that when you put a stent inside, the urine is draining by the side of the stent. Is that right?
Yeah.
Most of the urine drains by the side of the stent and not through the hole of the, not through the stent at all. Okay? Is that correct or not? Is that right?
Sir,
You're not sure?
it is through the, it's be through the stent, sir.
It's through the stent?
I think you need to read up, all of you. Okay. Drainage mechanism with stent is of 3 types. Please go and read. The majority of the drainage is around the stent, not through the stent.
So you see what can happen if the ureter is narrowed by compression from outside.
Yes.
The stent will occupy, what is the diameter of the ureter?
Around approximately 3.
What? 3 what? Inches, centimeters, feet?
You've seen so many of them, man.
What, man? Every day you're seeing the ureter. Every day you're fooling around with the ureter. You see, if you compare the diameter of the ureter with the diameter of the stent, depending on the size of the stent that you put in, and if the ureter is already compressed by a plaque, the amount of space between the ureter and the stent is reduced.
Yes, sir.
So the stent is effectively going to produce an obstruction to the flow of urine.
Yes, sir.
As a result of which the hydronephrosis could worsen, or if you're putting it for renal failure, the kidney function may not improve because the ureter is still swelling. So you have to be sure that the hydronephrosis actually settled in this patient. Right?
Yes.
It's very important. So that is why in a situation like this where you can monitor much more easier, you start these patients on medical treatment, whatever you're comfortable with. It may be steroid is the most commonest thing that is used.
Yes.
Every one of these drugs has got a potential side effect, so you must know about it. If you don't know about it, send it to the rheumatology fellows or the immunology fellows who deal with this.
Yes.
And there's a schedule for all these patients. And we have a schedule for steroids. I only use steroids because we are so familiar with it. So we know what the side effects are. But if you're a transplant, you'll know about mycophenolate, you'll know about azoran, You can use tamoxifen. These are all drugs which are available for the use of this. And you monitor the inflammatory markers as you go along. And you keep looking at the patient's well-being. So there are patients who may get away without any intervention just by medical treatment.
Yes.
You can have 2 years of you should have 2 years of medical treatment sometimes. So it's very important to understand there's a lot of literature available. Quite a lot of literature written in the British Urology book. So you look at that because recently also there was a review article in BJUI on this issue of RPF and medical treatment and all that. So, look at that, where they have actually given the medical treatment for 2 years. It was in BJUI. And, good review article. So you're going to read up. I thought you would be upfront on this because the theory question was this, no?
See, of all the drugs, steroids still are the safest and most effective. You just have to monitor for the complications and side effects of steroid therapy. Surprisingly, we've used low-dose steroids and it's worked.
Yes.
Yeah, you can actually, but most of us would probably start with a
30 milligrams.
with a heavier dose and then taper it down over 6 months and then maintain it sometimes for 2 years on these patients and keep them on. And if they don't respond to treatment or if there's worsening, then you've got to step in and decide what is to happen. It is advisable to operate when the inflammatory markers have settled. Advisable, but sometimes it's not possible because of the nature of the disease itself. But there will be a response.
What operation will you do, Priyanku?
Sir, erythrolysis.
That is the goal.
Yes, sir. So,
Goal is erythrolysis. So, what all operations are available for you? You should not only be doing erythrolysis,
You do
you
something.
should also, yeah. Please go on.
Erythrolysis plus something else.
so biopsy of the fibrotic area, sir.
Okay, you do that. Then, but you can't just do that and leave the ureter alone, isn't it? After doing erythrolysis, if you leave the ureter there, it will come and get same place, isn't it?
Repositioning of the ureter, sir,
Yeah.
into the peritoneal cavity and closure of this of the peritoneum with ornamental wrap around the ureter, sir.
So this is done. This is called intraperitonealization.
Intraperitoneal.
So this is done. You are doing extraperitoneal approach, isn't it?
Yes, sir.
Extraperitoneal approach, then this is what is done. But most of the time, the disease is bilateral, and therefore most people go through the peritoneum, isn't it?
Yes, sir.
Yes. What's the other option apart from intraperitonealizing the ureters? What else can you do to the ureter?
Lateralization, sir.
To the peritoneum, can you do anything else to it?
The lateralization.
Yes, lateralization.
Yes.
So you bring the peritoneal leaf and suture it over the plaque and keep the ureters aside.
Yes, sir.
What is the most favored operation? What is the most favored operation for RPS? What, man?
Ileal ureter, sir.
You didn't do the theory question at all, eh?
So ileal ureter is an option.
Ileal ureter, eh? What?
So if it is a badly plastered ureter, we cannot mobilize, then ileal ureter is an option.
Please answer the question. The question is, what are the operations done for RPS? One is
Lateralization of the ureter, intraperitonealization, ornamental wrap can be done, or
yes. So that is the most favored procedure done, where you lift the ureter off the plaque and wrap it around an omentum for two reasons. Why do you use omentum?
Vascularity, sir. It will maintain the vascularity.
इसका आंसर करने दीजिए प्रियंका को.
yes, sir.
What else will it do apart from vascularization? See, it forms a nice soft bed because the ureter. Have you seen operated on ureters where they've already done one operation? How badly it gets stuck to the psoas major and everything else? don't see
Yes, sir.
lithotomies these days.
Yes, sir.
You have seen a ureter after ureter lithotomy. You may have done the most brilliant ureter lithotomy, but the ureter gets stuck when you go the second time. It is at your smart major. Sometimes you peel it off, you find the streak of the smart major coming. So these are real things. So to prevent that adhesions, this omentum produces a bed. So apart from vascularity, it just produces a bed for this ureter to sort of snuggle in and keep peristaltic. We told last time that sometimes when you take this ureter off, it absolutely looks devascularized, looks like a dead snake without any peristaltic activity. And as a result of which stricture formation can occur in the long term. So you must be careful.
Again, in the mobilization of the ureter, you have to be very careful. You get very enthusiastic and devascularize the ureter, you can't save it with anything. There must be nice videos on this. Look for them. Kamal,
Yes, sir.
look out for some nice operative videos for RPF.
Okay, sir.
Share it in the group because, yes, it's a rare condition sometimes and one may not have seen
Yes, sir.
what's done.
Yes.
Anything else in this?
No, sir.
Any questions?
Sir, steroids should be continue even after surgical management of bilateral ureterolysis, sir?
Generally, no. See, that's why you wait for the inflammatory markers to come down because post-operative steroids carry their own complications. So generally the practice is to stop the steroids for a couple of weeks if the markers have settled down and then operate.
Okay, sir.
Will the pain go away?
Hardik?
No, sir. We did, sir, bilateral RGP and stenting, sir. It's showing L5 to S3 levels are narrowing.
Then I'm asking, after you do the ureterolysis, lateralization, omental wrap, and everything, will his original back pain go away?
No, sir.
That is another thing you'll have to warn the patient. If you saved your kidneys, for your pain you require treatment.
Yes.
Okay then, thank you all.
Thank you, sir.
We'll catch up next week and a happy Navratri and Dasera to everyone.
Thank you, sir.
Thank you,
Thank you,
sir.
sir.
Same to you.